I'm just trying to get my slides onto proper. Oh, it's actually having me join as a panelist.
Okay, that's great. Then you should be able to share your screen right away. Okay, so once I see you on the list, I'll hang up the call.
There we go. Okay. Let me share my screen. I'll move that over. What do you see?
Yeah, I can see your opening. I can see your PowerPoint.
Okay.
Yeah.
I would have it on. Now you see the PowerPoint only?
Yeah, perfect.
Okay. So I only have about 30 slides. I'm hoping not to talk too fast.
Sounds good. Hello to those on the line. We're just going to wait for some more people to sign in and then we'll get going. I'm in Vancouver and it's still dark here.
Thank you for getting up early.
Oh, that's okay. Surprised how dark it is at this time of day.
It's looking pretty dreary here, but
Yeah.
it's 11 o'clock, so.
You haven't had any snow yet, have you?
The other day there was a little bit of snow on the ground when we woke up. Didn't last very long, but it did continue to snow a little throughout the day.
Is that normal for Ottawa or early?
I think for London, well, I haven't been in London for too long, so I think it's probably, well, I did live in Ottawa at one point, and it's certainly a bit colder there than here, so wouldn't be surprised if they had snow as earlier than us even here.
Oh, so you're in London.
I'm in London, yes.
Yeah, okay. All right. Good morning to those of you who just joined. We're just waiting for a few more people to log on and then we'll get going. Okay, well, it is the top of the hour, so I think we'll get going. Welcome everybody to this webinar. My name is Fiona Lewis and I'm the Patient Support Liaison for AMAC. AMAC is a leading funder of research into bone marrow failure diseases in Canada. And we support patients and caregivers across the country who are living with aplastic anemia, myelodysplastic syndromes, and PNH. This year, we've been pleased to offer a number of regional in-person meetings, and we're going to continue with these in 2024. And we also continue to offer monthly Zoom patient support meetings. And on November 18th, just in a couple weeks, we're going to be hosting another webinar, this one on caring for care partners. So I encourage you to look into all these different services that are listed on our website, and you can also register for any of those sessions through the links there. We also have on our website a lot of other patient support resources that you may want to check out. So your line will be muted during today's presentation, but I encourage you to type any questions you have into the Q&A feature, which you can see if you hover your mouse at the bottom of your screen. And I'll address those questions at the end of the presentation. And if there's time, we'll also unmute the lines, so you could just ask your question verbally if you prefer. Please note that today's webinar will be recorded and posted on our website next week sometime. So it's my pleasure to introduce Dr. Ho to present today's webinar regarding MDS and new treatment options. Dr. Jenny Ho is an assistant professor at the Schulich School of Medicine and Dentistry at Western University. She did her medical and hematology training at the University of Ottawa, and she's completed a subspecialty training at the Princess Margaret Hospital at the University of Toronto. So with that, I will turn it over to her to begin the webinar. Thank you, Dr. Ho.
Oh, thank you. Thank you, Fiona, for the introduction and for the invitation to present to on this platform. And thank you to everyone for joining on a weekend. It's very much appreciated. So today we're going to be talking about myelodysplastic syndrome, and I was asked to talk about treatments. And so at the end, sorry, just give me a second here. At the end of this talk, I hope that we can achieve these objectives. So first, I hope that you're able to acquire some basic understanding of what myelodysplastic syndromes are, and this will be often abbreviated as MDS. Two, to understand the factors that can affect MDS risk. Three, to understand the approach to MDS treatment, and also to acquire some basic knowledge regarding the various treatment options for higher risk MDS. So just to begin with some basics, so a bit of understanding of where or how blood cells are made. First of all, the factory that makes this is our bone marrow. So our bone marrow consists of many different cells, but the main cell that is responsible is the blood stem cell, as indicated here. So the blood stem cell, or hematopoietic stem cell, you may hear it referred to as, is responsible for making all our blood cells. And in particular, it makes red cells, and what's important for carrying oxygen to provide oxygen to all our tissues. It also makes white blood cells, and these cells are responsible for our fighting infections and make up our immune system. We also make platelets, which is responsible for making blood clots and preventing bleeding or minimizing bleeding. So what are myelodysplastic syndromes? Medically, we can define it as clonal hematopoietic neoplasms that are characterized by combination of persistent unexplained cytopenias and morphologic dysplasia, and a propensity to progress to bone marrow failure or an acute myeloid leukemia, which is an aggressive form of blood cancer. So that's very medical. And so when translated, what it really means is that it is a group of blood cancers wherein the bone marrow, and that's our factory, right? That cannot effectively make normal blood counts. And this is because there's dysplasia present, which I'll explain a little bit later. This leads to a progressive worsening of blood counts over time. And then there is also an associated increased risk of developing acute myeloid leukemia with these disorders or disease cancers. So what is dysplasia? So dysplasia is present when we see abnormal cells in tissue. So we can get dysplasia throughout our body, but in the bone marrow, when we have dysplasia, we can have something called myelodysplastic syndrome. So up on the top picture is normal bone marrow. It is filled with a number of different cells, but just to highlight one normal cell here, this is a white blood cell that's a neutrophil. And what we see is in the middle, this is a normal nucleus that contains all our DNA, but on the outside of that, in the cytoplasm, we see little speckles, and these are granules. And when we look at a dysplastic bone marrow, an example here of a neutrophil, early neutrophil, where they don't have any granulocytes. And so that is a form of dysplasia, okay? So ultimately, when we have dysplasia, what happens? What are the effects on our blood? What we can see is one or more cell types, becoming reduced in number. And when we see a reduction in number, we call these cytopenias. We can have one or more, and it can be in various combinations. So when we have dysplasia, what happens is we can have reduction in one cell line, such as red blood cells, causing anemia, or we can have a reduction in neutrophils causing neutropenia, or reduction in platelets causing thrombocytopenia. And again, it can be varying combinations of these cytopenias, okay? How do we diagnose MDS? First, we suspect it in individuals who have persistently low blood counts, and that can't be explained by any other causes. So patients, as indicated before, can have anemia with or without thrombocytopenia, with or without neutropenia. Now, to make this diagnosis, we do need to look at the bone marrow directly to look for signs of dysplasia, as shown earlier on the earlier slides. When we do a bone marrow, we obtain a liquid sample, and we also obtain a core biopsy. We send these off for a number of tests, not only to look under the microscope and to perform some specialized testing called flow, but we also do molecular testing, which is very important in a lot of other blood cancers and as well as MDS. So one particular type of molecular testing is called cytogenetics, and this will look at the chromosomes that are present in the myelodysplastic cells. And in addition to that, we have more recently been sending off to look for gene mutations in genes that have been shown to be commonly mutated and affected in MDS and other similar types of blood cancers. Okay. So what symptoms can be experienced by patients who have MDS? It can vary from patient to patient, and in some, it can even present very asymptomatically. And in these individuals, they will perhaps go to their GP for a regular follow-up. Routine blood work is done, and they note low blood counts, and they follow it for some time, and those persist. And a patient actually feels quite well and is surprised that there's any abnormalities. And it can range from patients who are quite symptomatic, and usually the symptoms reflect patients' the low blood count, so the type of cytopenia they have, and also the degree of how low those counts are, how cytopenic. So patients with anemia, if they have mild to moderate, may have some fatigue and weakness. But if it gets more severe, they can get dizziness, feel lightheaded, have shortness of breath. That can be with more exertion at the beginning. And if it gets severe enough, patients can be even short of breath at rest. In patients who have a cardiac history or a history of heart angina or heart disease, they may even have chest discomfort or worsening angina when they have anemia. If you have thrombocytopenia, again, that's low platelets, which is important for forming blood clots. When you have obviously low platelets, then you are at risk for easy bruising and also more for bleeding. And the bleeding can be variable from mucosal bleeding, such as bleeding from the nose, from the oral mucosa, or even from the GI tract, and more seriously, internal bleeding. Neutropenia is when we have the low white cell counts, and with neutropenia, depending on the severity, certainly the more severe they are, the more at risk we are for recurrent infections. So how fast does MDS progress? Again, this is quite variable from patient to patient. It can progress slowly over many years in some, and then in others, it may be more rapidly over months. So what are some of the risk factors that can help us to determine who is going to progress faster or slower? The risk, MDS risk, can be estimated, by considering a number of different clinical factors. So we can look at the number of cytopenias that are involved, the severity of cytopenias. We also look in the bone marrow at something called blasts, which are the immature blood stem cells, and look at how high that blast percentage is. Genetic abnormalities that are present also play a role. So these are the chromosome abnormalities that I brought up earlier, where we determine these by doing cytogenetic testing. And again, even gene mutations now have been shown to have prognostic value. So MDS risk can be estimated by calculating a prognostic score. It can predict overall survival and risk for progressing to AML. There are quite a few number of prognostic systems that have been developed over the years. These are three of some of the more common ones. Certainly, the IPSS is the first prognostic score that was developed in 1997. Following that, the revised IPSS refined the clinical factors that were utilized to develop the initial score. And then more recently, a molecular IPSS looks at the considers the same similar clinical parameters, but also now includes gene mutations that have been known to be involved in MDS. So prognostic scoring systems, as I just mentioned earlier, the IPSS, which was the first one developed in 1997, again, looks at number of cytopenias, the blast percentage, and the specific cytogenetic changes. The refined these above factors to better classify patients and kind of help us to come up with a better estimation of risk. And then the molecular, as I said, added gene mutations. So each prognostic scoring system generates different risk groups, so they can't really be directly compared. So the first one, IPSS, categorize patients into 4 different risk groups, and survival in these risk groups were somewhat variable in that it could be quite low at less than 1.2 years, and then was as high as 3 and went up to more than 3.5 years in the 2 lower risk groups, which was intermediate 1 and low. But we clearly knew that there were better. It wasn't as refined. So refinement of this a little bit more by looking at the degree of cytopenias and other cytogenetic changes, and refining the blast percentages helped to actually categorize patients a little bit better. So we now have, using the IPSS-R, 5 different categories where there are 2 lower risk groups and 2 higher risk groups and an intermediate group, where we can see patients who have higher risk. These median survivals can be less than 1.6 years, but there is quite a bit of variability in those who have lower risk, and these patients' survivals can be 5 or more years, and even as high as 10 years. And then the intermediate category are patients who fall in between that. So how do we treat MDS? The treatment approach, and again, treatment can be variable from patient to patient. As you can see, the disease can be quite heterogeneous. Some patients who can only require monitoring of blood counts. These patients would likely have lower risk disease and have milder cytopenias or low blood counts. And monitoring can proceed for many years before any treatment may be required. Treatment options that are available to for those who require treatments, options that are available will depend on a number of different things. Certainly the MDS risk, whether it's high versus low, the severity of cytopenias, patient age and other medical conditions, and their overall health. Genetic features related to MDS can also play a role. So certainly supportive treatment is a major important treatment option for all patients, regardless of disease risk. So patients with low risk disease can become transfusion dependent. And when patients require transfusions for symptomatic anemia, we give red cell transfusions. The threshold for when we transfuse patients with anemia isn't quite rigid or set at a certain number, and it's really dependent on when patients are symptomatic. Often when hemoglobin levels are less than 70, it is not uncommon for patients to require red cell transfusions. Some patients may require transfusions at higher levels, in the low 80s or because of symptoms. When patients have thrombocytopenia, platelet transfusions can be considered. It is indicated when there is bleeding and platelet counts are severely low. Severely low or severe thrombocytopenia could be categorized with platelet counts of less than 50. Okay. Now, in the absence of bleeding, platelet transfusions can also be indicated if the platelet counts are very severely low. And this is often used, a cutoff that's used is less than 10. Another supportive treatment is the use of antibiotics. And again, would be used in patients who are high risk or low risk. And antibiotics are certainly used and initiated quite urgently if patients have neutropenia and who are suspected to have bacterial infection. That's because when patients have neutropenia, bacterial infections or any infection can present more severely than other patients who have a normal immune system and normal neutrophil count. Now, moving on to treatment of anemia, beyond the supportive care with transfusions, we do have a number of options, and predominantly these options are for patients who have lower risk disease. So in patients who have lower risk MDS and who have symptomatic anemia, we can consider erythropoietin stimulating agents, or shortened as ESAs. This is a recombinant form of a endogenous hormone that we make ourselves. It's made in the kidneys and called EPO, or erythropoietin, and this helps to stimulate our bone marrow to make more red cells. We can use ESAs if a patient's serum level of EPO is less than 500, and in these cases, we would initiate something called epoetin alpha, or EPREX, at 40,000 units. And you give it subcutaneously on a weekly basis. We would assess the response after about 4 weeks, and if there is not a adequate increase, we can increase the dose to 60,000 units and give it weekly as well. Okay. Another treatment for anemia can be considered in a specific subtype of MDS, and this is MDS with ring sideroblasts, with or without a specific gene mutation in a gene called SF3B1. So if you look over on this slide here, what ring sideroblasts are, you can see these are the cells here that have the little blue speckles around the nucleus. These blue speckles are mitochondria that have accumulated iron, and they stain blue on a special stain. So these are called ring sideroblasts. Patients who have this type of a subtype of MDS and who are transfusion dependent for red cells, and who have a lower risk MDS, as defined by the IPSS revised score. So patients who have very low or intermediate risk may be a candidate for a drug called luspatercept. Okay, this was recently approved and can be used as potentially as a second-line therapy, and it would be patients would be eligible if after failure of an ESA, or if they were deemed ineligible for ESA initiation. And this is based on a trial called the Medalist trial, published in New England Journal in 2020. This was a trial that was a phase 3 trial, double-blinded, and it was randomized and placebo-controlled. So again, patients who had MDS with ring sideroblasts were enrolled in this study. And again, just more specific for the study, they had to have a diagnosis in the bone marrow and had to demonstrate the following. Okay. Patients also had to have red blood cell transfusion dependence, and had to fit into a lower risk MDS category that was defined by the IPSS-R. And those again were low risk, very low or intermediate risk. So patients were randomized to receive either luspatercept every 21 days, and this is given as a subcutaneous injection, or they were given placebo. And they monitored the following outcome. This was the main outcome. They assessed what was called RBC transfusion independence for 8 weeks, meaning that over an 8-week period, a patient did not require any red blood cell transfusion or for 8 weeks or longer. And they monitored this for during the first week to 24 weeks, which is half a year. These were the results of what they found. So when they looked at that transfusion independence for more than 4 weeks, they show that. So patients in blue received luspatercept. Patients who received placebo are in the brown or red. So certainly we saw a higher proportion of patients, 38 to 4, it's almost 40% of patients who actually achieved transfusion independence for more than 8 weeks or longer, and compared to 13% who received the placebo. Now, if you were to look at patients who were transfusion independent for even more than 12 weeks during that same period, there was about a 28% there compared to 8. And then for those who sustained more than 12-week transfusion independence, and for even and if they looked over almost for 48 weeks, almost up to a year, about 33% had achieved that outcome. So these were quite positive results. And as a result of that, this medication has been approved for MDS in this scenario. Okay. Another treatment for anemia can be given in another subtype of MDS. And this has been a treatment that has been available for longer than luspatercept, and it is used in patients who have what we call a del5q or a 5q minus. You may hear it referred to as cytogenetic abnormality. So this cytogenetic abnormality is shown here on the left, and it affects the 5th chromosome. So what you can see, we have pairs of chromosomes. So this is a normal chromosome 5, and this is the chromosome that's been affected. So you see that there's a shortening of the longer arm on the bottom here. And so what we call a del, meaning a deletion. So this shorter part has been deleted, or this has been deleted from the long arm on the second chromosome 5 here. So these patients who have this del5q, and if they have symptomatic anemia and lower risk disease, and lower risk as defined now by IPSS, because the studies at that time enrolled patients who, according to the IPSS, so if you have low risk or intermediate risk, you may be eligible for something called lenalidomide, also called Revlimid. So patients with this abnormality make up about 10 to 15% of MDS cases. Patients typically present with anemia, what we call macrocytic anemia. They can, in about 30 to 50% of patients, they have actually high platelets rather than low platelets. They also have a favorable prognosis, and although they can respond to EPREX, which is the injections, the EPO injections, their responses are usually of shorter duration. So in this MDS 004 trial, this was a phase 3 study that looked at lenalidomide in patients who had this del5q deletion or cytogenetic abnormality. And they randomized patients to 3 different groups. It was also a double-blinded multi-center study. And again, patients who had low-risk disease, as defined by the IPSS score, were enrolled. They had low or intermediate 1 risk. Patients received either lenalidomide at 10 milligrams for 21 days, which is 3 weeks out of a 4-week cycle, Or in a second group, they were given lenalidomide at a lower dose, but daily throughout without any breaks, or they were given placebo. And the outcome that was monitored here was RBC transfusion independence. So no requirement for any red blood cells for a 20-week period or more. So the results from this, if you look at the three different groups, the patient 56% of patients in the first group who were given 10 milligrams of lenalidomide achieved this outcome. Patients who were on the lower dose, 42% achieved this outcome, and with placebo, only about 6%. So as a result of this and various other studies, lenalidomide is approved for treatment of anemia in del 5Q MDS. Now, moving on to treatment of higher risk MDS. So patients who have lower risk MDS would not qualify for these therapies. So higher risk MDS, we don't, certainly patients with this type of MDS are at higher risk for progressing to acute leukemia and for having shorter survivals as a result. At present, our only real curative option is allogeneic stem cell transplant, unfortunately. Now, even though we have this curative option, eligibility for this procedure really depends on a number of factors. There's disease-related factors. So again, as I indicated, MDS risk, so higher risk disease patients with higher risk disease would be eligible, and also blast percentage in the bone marrow. So if we have a higher percentage of blasts, it may be necessary to try to reduce that blast percentage prior to any transplant. And also patient factors, related factors are important. So patient age, medical conditions, and performance status. This is a procedure that has a lot more risks associated with it, so increased morbidity and mortality. So because of that, we have to take into account patient factors in order to ensure that the risk of the procedure outweighs the risk of the disease. And so for patients who are ineligible for stem cell transplant, we do have chemotherapy options for higher risk MDS. The real mainstay for in terms of chemotherapy are what we call hypomethylating agents, or what can be you'll see shortened as HMA. We have injections that are available. So these have to be given as subcutaneous injections or IV in the case of decitabine. So azacitidine is what we have available here in Canada and is given as a subcutaneous injection. There was a phase 3 study of azacitidine that compared that to conventional care. This was published in 2009. And it showed that median survivals were higher in patients who were treated with azacitidine compared to those who were treated with conventional care. There was about a 10-month increase in median survival. So azacitidine and hypomethylating agents have been standard of care for more than a decade for MDS, higher risk MDS, that is. And how we give azacitidine, it is as an injection, as mentioned earlier, and it's given for, in the studies, it was given 7 consecutive days, but, it is not practical to give that for 7 consecutive days, in practice. So what is done is that we do this, can give it for 7 days with a 2-day interruption, and that 2-day interruption is for the weekend. So we give it for 5 days during the week, with a 2-day break over the Saturday and Sunday, and then we resume for 2 additional days following that. Okay. And that this is a graphic from the study showing azacitidine in blue and conventional care survivals on this plot here. So it can take a number of, so I should go back. Azacitidine is given for 7 consecutive days in a 28-day cycle. So it's given every 4 weeks, okay? And what's important to note is that it can take a number of cycles before a response is seen. And sometimes it can even take up to 6 cycles of chemotherapy for, in some patients, for a first response to be seen. I tell patients that we're likely to see initial worsening of blood counts before improvement is observed. Because of this, certainly count checks with transfusion support, if our counts do drop further, are required. And also a risk of infection is increased as well when we initiate these treatments because of the potential worsening of our neutrophil counts before we see improvement. Now, more recently, so decitabine has been is approved in the U.S. as but not in Canada as in the form of injections. But more recently, oral formulation of decitabine that includes another component called sitazuridine, or called this pill is called Incovi, has been recently funded for use in MDS. I said, is an oral formulation of decitabine, and the addition of the sitazuridine inhibits an enzyme called cytidine deaminase, which is an enzyme that can degrade decitabine in the gut and liver, that can then lead to lower levels in the blood. So that incorporating that into the pill allows for more systemic exposure of the decitabine component. What this preliminary study, what the studies have shown, phase 3 study showed that Incovi can be equivalent to the injectable form of decitabine, but there is no study at this present time that has directly compared Incovi and azacitidine side by side. So at this present time, although we have Incovi, it is very likely that more patients will still be treated with azacitidine at present. I think Incovi would be useful in patients who may not be able to come back and forth to hospital for injections. However, Incovi still has the same myelosuppressive effects of azacitidine, where your counts will drop before they improve. And there's a possibility that it may be perhaps even more myelosuppressive than the injectable form of the decitabine. So patients would still need to be able to come back and forth to hospital for count checks and transfusional support. So although it is an oral form that you can take at home, it doesn't eliminate the need for still travel to hospital for supportive care. So future treatments would likely involve combination treatments with hypomethylating agents. Currently, there are a number of different HMA combinations that are in clinical trials, but we haven't identified a clear combination that is fully effective or superior to azacitidine or decitabine alone at this present time. But certainly hopeful that we may be able to find something. Now, I think it's important to recognize that the impact of MDS has on patients, and certainly on the quality of life, and a number of factors. do impact that, namely, symptoms related to the cytopenias. And if these cytopenias are severe and require transfusions, there's a lot of time and commitment to transfusion appointments that can be quite difficult for this population of patients. Also, if cytopenias are severe, complications can be serious and life-threatening, and so leading to a lot of clinic visits or hospital visits or hospitalizations as well, and also the worry and stress that certainly come along with having a diagnosis. So certainly quality of life, do acknowledge that can be impaired when we have a diagnosis of MDS. So these are just a few extra references that were not included in the main bodies that I just wanted to make sure I included. I'm just going to stop sharing here. Okay. Oh, I think you're still on mute.
Sorry, thought I clicked that. Thanks very much for that. We'll just open it up to any questions. So you can either type your question or you can click on the raised hand icon there at the bottom of your screen, and I can unmute you so you could ask your question. Okay, someone's asked if you could please speak to CCUS with chromosome 8 trisomy.
Pardon?
Someone asked if you could please speak to CCUS with chromosome 8 trisomy.
I mean, CCUS, is that what they mean?
Yeah, looks like it, yeah.
So I can't say I know. I don't think I can answer that. I don't know enough about that trisomy and then the context of CCUS. I apologize.
Okay. Any other questions from that person or anyone else? I had one about the prognostic scales. You mentioned the IPSS and the IPSSR. Mm-hmm. Will the IPSS eventually be phased out and everybody will have an IPSSR score?
So I think the reason why we still continue to use the IPSS, even though it's older and certainly doesn't risk stratify as well, as you can see based on those graphs, a lot of our drugs were tested in the era where we use the IPSS. So some of the drug funding and criteria to fit criteria for eligibility still fit or use the IPSS. So in some of the use of azacitidine and the lenalidomide, those studies had included patients who had IPSS scoring done. The newer studies are probably, incorporating now IPSSR. So because of that, it is still something that I still calculate and still use because of that. So I would calculate both.
So a newly diagnosed patient would likely get both scores?
Yeah, so I make note of what they are for both, yeah.
Yeah, okay, thank you. There's another question from Nancy. Maybe I'll just unmute you, Nancy, if you'd like to ask your question.
Oh, hi.
Hello.
Hi. I understand there's age limitations for stem cells transplants. And I wanted to know, I'm 71, otherwise healthy. And I was told that's the only cure for eventually when I develop MDS, if I do, but it looks like it. Why is there a limitation if you're healthy otherwise, but you're 71 and at least in BC, it stops at 70. I understand Alberta, it stops at 71. So
I'm not a transplant doctor in terms of being able to say, whether or not I would consider, I think it varies. And so in some places, as you indicated, they have a ceiling. In other places, they may not have a hard number. I think certainly we may say patients who are 70 or younger can still be considered. I think a little bit older, I think maybe in some centers may consider still patients, but it would be maybe perhaps on a case by case basis.
Okay, thank you.
You're welcome.
Thanks. We have another question. This person says, my hemoglobin has been going down over the past 2 months. It's gone from 10.7 to 10.2, and this week to 9.8. At what point would you start working one up for an SCT, stem cell transplant? I'm 46 with ringed sideroblasts and ASXL1 mutation. Lots of info there.
So I think in terms of working up for a stem cell transplant, well, first of all, we'll go to the question about the anemia. I think in patients who have a diagnosis of MDS, I think it's always important to remember that worsening anemia can be from not only MDS, but can be from reversible causes. So I think a hematologist would normally all want to work up and look to make sure that there isn't any other contributing cause for the worsening anemia beyond MDS. So making sure that there's no nutritional deficiencies or any signs of bleeding as a potential cause, or breaking down of your own red cells as a cause. So I think working that up to ensure, and if those are fine and it's related to the disease, I think the decision to transplant still would really depend on the disease risk. So if your disease risk, if nothing else has progressed and it's only been one, I think it depends on how, the more cytopenias you have, the more severe they are. And if your disease risk increases, or on a repeat marrow, we see things have changed, or there's more now increased blast that can then increase your disease risk, that's when we would want to consider stem cell transplant, because in lower risk disease, the risk of transplant would not outweigh the risk of the transplant procedure itself, because it does come with complications and increased mortality and morbidity. So I hope that answers the question.
Thanks. Any follow-up there with that question? Yeah, I was just going to mention, we certainly have people who join our patient support group calls who have gone through the procedure of the stem cell transplant. So definitely lots to learn from them about their experience and some of the complications, but some of the successes too.
Yeah, yes, so it's good to hear those for sure.
Mm-hmm, mm-hmm. Any other questions? See any? Okay, well, we can close off a few minutes early. Thank you, Dr. Ho, for giving a really concise overview of MDS and treatments, and for making it easier for lay people like us to understand. We appreciate your time today. And I just want to
Thank you.
again remind everyone we have some other interesting webinars coming up. So please look at our website and find out more about those and how you can register. And we're also putting out our fall newsletter very soon, which actually has a story about a woman who received a transplant recently. So if you're not receiving our newsletter, you can sign up for that on our website as well. And oh, we just have someone weighing in with thank you as well. So with that, I'll close things off. Have a great day, everyone. And thank you very much for joining us.
Thank you.
Thank you.